Good afternoon, everyone. I just wanted to let you know if you were intending to join us for our community partner Medicaid waiver meeting, you are at the right place. Just continue to hang tight. We still have people logging in. Appreciate your patience. Thank you.
Thanks for your patience with me, Ruby. I have to leave at 2:30, but Bruce Cross here.
Can you hear me? Can you hear me?
Hello, we can hear you.
I didn't know you were on yet. I was just testing it. Thank you.
Oh, no worries. We'll be getting started soon.
Okay.
Good afternoon, everyone. It looks like we have about a quarter of our people logged in. So just bear with us. We're going to go ahead and get started. I want to be respectful of everyone's time. So I will go ahead and get us started here in just a moment. All right. Well, welcome, community partners. We are so grateful that you're joining us here today and taking time out of your busy schedule to learn more about our Medicaid waiver. We've been talking about this for probably about 2 months now in our community partner collaborative meetings. So for those of you who participate in those collaborative meetings, I'm sure you're familiar. All the different regional outreach coordinators across the state reach with or connect with their community partners to talk about everything Oregon Health Plan, the latest and greatest. So we've spent quite a bit of time talking about this for the last 2 months. And for those of you who are not a part of the community partner collaborative meetings, feel free to add your email to the chat box. And we are happy to add you to our distribution list. Just let us know what county you're in. So again, if you are intending to be part of the Medicaid waiver community partner meeting, you are at the right place. So just a few things. We are recording the meeting today. We have about 190 people who have registered. So clearly our community partners are excited and really looking forward to being a part of this conversation. I also wanted you to know that we will be holding a meeting in Spanish, and that will be taking place on Thursday at the same time. If you'd like to invite your colleagues to our Spanish meeting, reach out to your regional outreach coordinator. All of us ROCs know where to find those invitations and registration links, and we can get those to you. The meeting is actually, you should be able to see closed captioning. So if you're having any issues with that, please let us know in the chat box. I do have a few people here with me today who will be assisting with the chat box, and that will be my fellow regional outreach coordinators, also known as ROCs, Jessica and Karina. So for those of you who don't know me, I'm going to start by just introducing myself. I'm Ruby Graven, and I'm one of the regional outreach coordinators, part of the Community Partner Outreach Program at the Oregon Health Authority. And the region I support is Washington County and Columbia County, along with Aini Amir. She's not here today. So basically what I do is work with all of you who are assisting with Medicaid and enrolling families day in and day out. Part of my role is to support you and to hear from you, to learn from you, to ensure that you have any updates that you need to get people enrolled in the Oregon Health Plan. And another one of my roles is to gather all the content from our team and get those into our community partner collaborative meetings. And Jessica, do you want to introduce yourself?
Thank you, Ruby. Hello, everyone. My name is Jessica Diaz. I'm also on the Community Partner Outreach Program team, and my role is statewide as the Provider Outreach and Engagement Coordinator. Excited to be talking to you today.
Thank you, Jessica. And Karina, do we have you ready to go and to introduce yourself?
Yep. Good afternoon, everyone. My name is Karina Reardon. I'm a regional outreach coordinator with the Community Partner Outreach Program, and the region that I serve is the Coast. So happy to be here today.
Thank you, Karina. And then Lori, it looks like you joined us. Do you mind introducing yourself to the community partners so they know you're on the phone with us today? She might be on mute.
Hi there. Let me get myself off mute and maybe.
You're good. You're good. I hear you.
Good afternoon, everyone. I'm Lori Coiner, and I'm the state Medicaid director, and happy to be here. I'm going to be quiet. And Ruby, sorry, I'm on mute, so it might take me a while to get off. But I'm on to listen and hear responses from everyone, and then answer any questions that can't be answered by the fabulous team that's presenting. So thanks, everyone.
Thank you, Lori. All right. Fabulous. So I think we have all of our presenters who have introduced themselves today. And it looks like we have about 90 people logged in so far. So remember, there's 190 people who registered for today's meeting. And I'm sure people will kind of be logging in a little late because it is a little after lunch. So I will try not to interrupt us too much. And since this is recorded, they can just circle back. Okay, so for those of you who have been a part of our community partner collaboratives, we're going to be talking about the waiver today, just kind of a general overview of like, what is this Medicaid waiver all about? You know, we keep talking about the 1115 waiver, demonstration waiver, and you hear these words. And I know some of the community partners have said to me, I'm not really sure what this is about. So we wanted to start by just kind of setting the stage and letting you know what we're referring to when we talk about Oregon's Medicaid waiver. Then we're going to talk about what we think the approach should be and what the timeline we think should look like. And then we need you to tell us if we're on track or if we missed the mark. So we wanted to start somewhere, and that foundation will be shared today. We'll talk in depth about community input. So everything we've heard from you as community partners, from families, from youth, community health workers, clients who are utilizing the Oregon Health Plan day in and day out. So a lot of this community input has been gathered and tracked for years now. This input came from CCO 2.0, from the strategic plan, state health improvement plan, and from our COVID listening sessions. So we want to say thank you, thank you, thank you to all of the community partners who have shown such strong leadership in gathering our community members throughout the years, who have given us all these creative ideas and ways to engage our communities. The input that came from mothers, fathers, sisters, brothers, it hasn't been lost. We've been tracking it. And so we want to say, here's what we have so far. Did we miss anything? Are we on track? What do we need to adjust? And then definitely there's going to be opportunities for questions. And as Lori mentioned, she'll be on standby in case we need answers from her. So Jessica, I'm going to go ahead and turn it on to you.
Thank you. Okay, we are going to start by talking about who or what is OHA. Next slide, please. So OHA is an acronym, one of many that us governmental folks end up using. The Oregon Health Authority is a state agency that includes most of the state's health and healthcare programs. You might be familiar with public health. It's definitely been a group of us who have been perhaps in the news a bit more with the pandemic. The Oregon Health Plan. OHA has a vision of a healthy Oregon, and we do really want to ground our conversation in the vision and the mission of the Oregon Health Authority. So I'll read the mission next, which is ensuring all people and communities can achieve optimum physical, mental, and social well-being through partnerships, prevention, and access to quality, affordable health care. And now something that isn't on this slide, but I do also want to share with you all, which is really going to ground the rest of our presentation, is that we have a series of core values at OHA, and health equity is one of those leading core values. So in order to reach health equity, we address the clinical and social conditions, historical and contemporary injustices so that everyone can reach their full health potential. And so that means that Oregon Health Authority is not only concerned with things that are happening medically, but also in our communities, in our environment. And in order to do that, we must respect diverse cultures, populations, histories, and health practices, and consider the diversity of Oregon's communities as we make decisions about how policy and practice are developed and how our resources are distributed. And then one last piece of this health equity is that we need to ensure that our workforce is diverse and inclusive, because a workforce and leadership that reflects Oregonians is best able to achieve these outcomes that we've laid out. Next slide, please. So now that we've talked a little about OHA, we're going to go into what Medicaid and the Oregon Health Plan is. And this is a very high-level overview. Medicaid is a federal program, and it is administered on a state level. So we have the Oregon Health Plan, which is what we are calling our Medicaid program here in Oregon. And the Oregon model uses coordinated care organizations, or CCOs, which are local OHP health plans that cover medical, dental, and mental health care. We have about 1 in 4 people in Oregon who get their healthcare coverage through the Oregon Health Plan. Next slide, please. And we have a poll question here. The question is, what is a waiver? And it looks like Ruby has popped up the poll. And the question here is, do you know what Oregon's Medicaid waiver is? Please select either yes or not yet and hit submit. And we'll give you some time to answer that poll.
Jessica, it looks like about 70% of our attendees today, of our community partners, have submitted their response. So we'll just hold on here for just a moment.
And then Ruby, are you going to show us the answer when you're ready?
Yes, I will be sure to do that. Looks like we need 15% more responses. So if you stepped away for a second, come back to your computer. We want to know if you've heard of Oregon's Medicaid waiver and if you know what that is. A lot of us are still learning, so we just want to get a good idea for the landscape here. So this really helps us understand when we're talking about a Medicaid waiver, it really helps us with how we're going to talk about it and what to include. Do we need to be talking about this in high level terms? Should we go into the weeds? Do we need more real life examples to really make sure we're on the same page? So for those of you who are responding to the question, thank you so much. It really helps us with our messaging and making sure we have all the right information ready for you.
This is a good time to remember too, as Ruby was saying, this is not the only presentation or conversation that we plan to have. So this will help us inform our future conversations as well.
Absolutely. I know that I've had a few community partners feeling, a little anxious that they've missed their opportunities to share input on strategies or policy work, and we are just getting started. So our community engagement opportunity is now. And if you're not sure what the Medicaid waiver is, please let us know. And if you know what it is, that's great too. All right, so I feel like I've given people enough time. So I'm going to go ahead and end the poll here. We got to, looks like we got to 85%.
That's not shabby.
All of a sudden, wait a minute. All the numbers are there. It looks like more people ran to back to their computers. Maybe people were making smoothies. I don't know. Get a quick smoothie in if you skipped lunch, right? Or maybe like Jessica, we were talking earlier, like we have people who sometimes go for a walk during lunch. Maybe people had to put some dry shampoo in their hair. Okay, I'm going to end this poll and share the results with you.
That's a pretty even split.
Yeah,
Looks like
it'll be pretty interesting, but the majority of our group today is still learning what a Medicaid waiver is. Fabulous. Thank you so much.
All right, I suppose we should start talking about that next then. Let's see here. Can we get to the next? Aha, perfect. All right. So what is a waiver? Today we're going to be talking about something that's called an 1115 research and demonstration waiver, but you'll probably hear us just call it the waiver more simply. So when it comes to the Oregon Health Plan or for Medicaid, there are eligibility factors based on income and other reasons. We have a lot of rules that come from the federal government to set the minimum standards related to eligibility and what must be required in the benefits, but states can ask to waive some of those federal rules in order to have more flexibility and to offer Medicaid to more people, to cover more services, to do things that are maybe more cost effective. There's a variety of reasons we can give for the things we want to waive, and that's a conversation that the state has with the federal government. So every 5 years, Oregon must renew its agreement with the federal government around the Oregon Health Plan, and what we do is we propose changes, we propose things that maybe have been working in our past waivers and we want to continue, and then we have that conversation with the federal government about which of these things we've asked to waive will go into the next 5-year plan, and maybe some of the things may be rejected as well. Next slide, please. A tiny bit of history on our 1115 waiver here in Oregon is that the original waiver was established in 1994 to establish the Oregon Health Plan, which expanded eligibility and benefits throughout Oregon. A few highlights is that in 2012, we were able to establish the coordinated care organizations through our waiver process, or at least in part. And then talking about the 2017, the most recent waiver update, we were able to improve the CCO model. We were able to promote increased investments in health-related and flexible services so that CCOs could invest in services that improve quality and outcomes of their members, expand that access to coordinated care, promote primary care, and really build up that patient-centered primary care home program to have value and also for better health outcomes. And we also were able to continue to advance tribal health programs in the 2017 waiver. So that's just an incredibly brief snapshot of some of the things that have been done through waiver. And next we're going to talk about what waivers are not, which is first off, and very importantly, the Medicaid waiver is not the only place we can affect change. So it's not the only place where how care is delivered is decided. There are also ways we can involve Oregon law, Oregon administrative rules. There are things built into CCO contracts and a whole host of other ways we can identify and fix problems. So being in the waiver is not the only way that something may change when it comes to the healthcare landscape in Oregon. Along those same lines, the waiver is not for fixing every part of the healthcare system. There are a lot of other places where we can advocate for change and give feedback. And the waiver is not a place to file a complaint about a specific provider or service. So if there's something that is not maybe systemic, but is very localized to a specific provider, some CCO has an issue, they need to resolve those directly, and there are processes outside of the waiver for us to do that as well. So the waiver is a lot of things, but it's not going to be the maker or breaker of every single change in our system. Next slide, please. Now that we've talked about what the waiver is, let's talk a little bit about our current timeline. I do want to start by saying that, as Ruby mentioned right off the top, this timeline makes it seem like we're sort of just getting started, but there are a whole host of ways in which the agency has been engaged and will continue to engage with communities, with partners. And so this is just our specific waiver project. This is not your only opportunity to engage with the Oregon Health Authority, for instance, but this is one way in which we're hoping to engage you. So we started with our first phase, which was early this year, and I think well into last year as well, which is identifying vision and goals and really building on the things that we've already heard from communities. We've already heard in, for instance, our state health improvement plan, CCO 2.0, and start to really identify what vision and goals are going to be central to our work. And some of that you're seeing in this presentation today. We are now in the public engagement section here. That's going to last just about through June, when we begin drafting our application, and that's the application that goes to the federal government for our next waiver. There's going to be another opportunity for public engagement set aside, I think around September, in advance of submitting any final application to the federal government. And so these first stages are project planning, application development, and submission. Then we get into the negotiation and approval portion of the timeline, which will start in early 2022. And then we will have June as our start for implementation. So we start in the planning, we're still deep in that now, and then we'll move on to implementation planning and that implementation in July 2022. Next slide. Now, this is a similar but slightly different way to show the timeline, which is step 1 is to analyze problems and identify potential waiver solutions. And that is the phase that we are currently in. Then we will move from that analysis into developing strategies and program details. And that is May through June. And then we will draft that waiver application to have it submitted at the end of this year. And we want to make it really clear, this is not a one and done. We've engaged the community. We are gathering stakeholder input. We will be in communication every step of the way. And I think Ruby did a great job of laying out some of those ways in which we have and will continue to get feedback and to interact and have conversations with you all, including that state health improvement plan, CCO 2.0, a whole host of conversations happening around COVID-19. So this is not your only opportunity, but it is a good one to share with us some of your priorities and what you all have been seeing. I want to double check, Ruby, if there's anything else specific to this slide that we want to cover, because I want to make sure I'm not missing anything. I think we're good.
You're good, yes.
Okay, so in that case, we can move on. So now we're going to talk about our vision, goals, and the problems that we want to address based on what we've heard from you all so far. And I'm going to go over the overarching one and then our first goal. So we are really having health equity be our central framework for what we want to make happen in our waiver. So we will focus on advancing health equity by doing these 4 things you see in front of you right now. Creating an equity-centered system of health, ensuring access to coverage for all people in Oregon, ensuring smart, flexible spending, and reinvesting savings across our systems. And we'll talk more about what that means. First, going into that first section, creating an equity-centered system of health. So what we've heard so far, people identify the racism in our system which prevents them from being healthy. Racism's impact as a system and also as a set of individual biased actions have persistent negative impacts on health, well-being, and wealth of communities of color and tribal communities. Inclusive, culturally, and linguistically appropriate care is needed for all. And there are many ways in which we have seen how not having access to this has created disparate situations for people. For example, the COVID-19 pandemic has disproportionately struck communities of color and tribal communities. Another place where we see this is that communities of color face greater challenges accessing housing. And we see some statements, some quotes here on this slide about what that has looked like for folks. We have talked about inclusive, culturally appropriate care centered on the role and importance of traditional health workers in tribal communities and communities of color. Linguistically appropriate healthcare services like interpreters, providers with lived experiences, and from communities of color. And so we have many ways in which we have had people identify how the racism in our system and individual actions of folks within our system prevents them from being healthy. Let's move on, please. All right, so to create this equity-centered system in health, we have to make sure that we are ensuring the health system works for communities of color in Oregon. And that means addressing the needs resulting from inequities and barriers that already exist and that lead to health disparities, and understanding the lived experiences of members to fix what is not working. And so we need to change the Oregon Health Plan to help members with complex needs and those complex needs that may stem from systemic racism. So we need a health system that is centered on advancing health equity and eliminating health inequities. And if we don't lead with that, we can just expect more of the same. Next slide, please. So our goal is that Oregon Health Plan members experience easy access to healthcare and other services, that they do not experience language, cultural, or economic barriers to their care, and that other services like housing supports, things that maybe are not in that medical field that we're used to considering with healthcare, are also covered and are an intrinsic part of this as well. And so a few strategies in there is to improve care and capacity across the behavioral health system, really look into those social determinants of health and those supports like housing, and to incentivize health equity in our care delivery across the state, as well as enhancing the coordination for justice-involved populations, making sure that coverage is something that is accessible. I think we're at our first pause for questions. So I'm going to take a pause here and we'll see if anything comes up either in the question box or if anyone has anything they'd like to say.
Yes, if anybody would like to turn on their camera, or if you want to unmute yourself, you're invited to do so. Or if you prefer to keep your camera off, that's okay too. I know some of you might be working remotely with kids in the background, or maybe you don't have the space that you need. Any questions so far? Let's see. I don't see anything in the question box. Okay, well, we will keep an eye out for that. So yeah, feel free to put in any questions as we move along. If you can't think of something right now, it's okay to add questions as we move along. Thank you so much, Jessica. All right, so based on what we've heard from our community partners and community members across Oregon over the last few years, as I mentioned in the beginning, from CCO 2.0, the strategic plan, state health improvement plan, and COVID listening sessions, or our collaborative meetings and our grantee check-in meetings when we're meeting with our contracted providers and different community partners. Our goal really is to focus on health equity and making sure that OHP members experience easy access to healthcare and other services, to be sure that there aren't any language, cultural, or economic barriers to care. You know, so for example, when you have a client who needs to see, gosh, I don't know, a GI specialist, and they're experiencing stomach pain, and they want to participate in an appointment in person, and that provider says you can see someone via telehealth. We want to make sure that that client or person has access to a computer so they can show their doctor where that pain is. And if they only speak Spanish or Korean or Russian, we want to make sure that that person has access to an interpreter so they can explain exactly what those symptoms are. And then another goal is to ensure our services like housing supports are available and covered, because we know when people have housing first, they can move on and start thinking about some of the other things in life that people need so we can all thrive. So with that, what are your thoughts? What are your experiences? And what is standing in the way of us getting to these goals? So what is in the way? And what do you think would support us in achieving these goals the most? And what I can do is we can keep an eye out in the chat box. So I'm going to give you all just a moment to do a silent read and sort of think about this and see what your thoughts are. So if we're quiet for a while, that's okay. That'll give us time to process. Okay, so it looks like we're getting, thank you, Antonia, some feedback here already. And I'm just gonna, you should all be able to see the chat box. If for some reason you can't, I guess I shouldn't say that. I shouldn't say you should all be able to, because it's very possible that your monitors are set up differently. So just some examples here. I think the public, specifically marginalized communities, need to be educated that they can have access to these programs. I would encourage more media outreach for educational reasons. Individuals can get phones through the CCO, but the issue tends to be data. Oh, so having enough data. We cannot tell a person they can only use data for appointments, so unlimited data would be great. Yeah, great idea. Unlimited access. Oh, sorry, Antonia, I spelled your name wrong. There is no database of providers that take open card, and the number to call for open card recipients is incorrect. Amy is saying she agrees, better vision care is needed. Vision care, vision care for everyone. We should all be able to see, right? Like we should be able to access glasses is what I'm hearing here, and eye exams, this is what I'm reading here. Also, I do a lot of coverage for folks coming out of correctional facilities. It is really hard to get them into treatment facilities because OHP won't cover them until they're released. Treatment centers won't hold a bed for them. And on and on and on is what she says here. What you're saying. Let's see, Audrey. Audrey, thank you. Language appropriate materials, both culturally specific in respective language and written in the way the community understands. Videos, written, etc. Thank you, Jackie. I so appreciate that. After getting all our OHP Covers Me outreach materials, we learned a lot from that work, and we have this beautiful report that someone I know put together, and it talks a lot about the good work that our community partners did in making sure that those materials were culturally appropriate. So making sure we don't just translate something through Google Translate, and inviting our community partners to be a part of that transcreation process and letting us know, you know, what works, what doesn't work. Everyone has a unique, customized perspective, so it's really important that we are collaborating with our community partners. We've learned that it's been much more effective, and we still have a long ways to go, quite frankly. So thank you, Jackie, for that input. Places to charge cell phones has been an issue too, and I recommend funding small solar chargers. That's a great idea. I recently saw something in the news about these tents in Portland that are supposed to be like a hard shell and are solar powered, and people can charge their cell phones in there. That was super innovative. Okay, so lots of input coming through here, and I just want to do a little time check. Okay, hearing complaints about phones and long waits, people being transferred several times. Expand on and provide additional resources for the use of peer-delivered services. Peer-delivered services can help create a more culturally aware system and process. Okay, somebody is asking a question about what we mean when we say housing support. It looks like that one came from Tammy. Currently have services to assist individuals moving out of licensed beds, but we cannot get them approved for the services if they don't have Medicaid already. So yes, making sure people have coverage, they stay covered, and they're not bouncing in and out is very much key. Open card is very hard to get patients into a specialist until they get on a CCO. Yes, we've heard that quite a bit from community partners. Is there's that, I think, Brenda, what you're talking about is when someone is first enrolled in the Oregon Health Plan, they have that sort of in limbo time period where they're fee for service, and then they get enrolled into their CCO. I think that's what you're talking about, Brenda. And for people who need urgent appointments, that limbo time can be very much life-saving. You know, if they need to see a specialist, and that continuity of care too is very critical. So most people need a referral if they have OHP to CNI doctor. So that's a barrier to reaching our goal. Thank you, Nicole. Thank you so much for taking the time. This is amazing. A lot of really valuable input here on how the work that we need to do to reach this goal. Thank you. Okay. Well, keep it coming. I'm going to keep us moving along, but please do, as you're thinking of anything new, or if you just want to reinforce something that a community partner or colleague shared across the state, please do go ahead and add that into the chat box, and we're going to keep track of that. Great. So, you know, one thing we hear time and time again is we need to be really sure at OHA that we're ensuring people have access to coverage, that everyone has, all people have access to coverage. And, you know, when I look at these words, I think about my time as a community partner 10 years ago. We have a few people on the team who were a part of this work prior to coming to our community partner outreach team. And I remember sitting down with families and signing kids up for, at the time it was called Healthy Kids for OHP when it expanded. And, you know, parents would be so excited to have that in-person assistance, and I'd walk them through the application in Spanish. We'd make copies of the pay stubs, and they'd give me their social security number if they had one. And if they didn't have one, they want to know what they could do to get coverage. And it was really hard to just be able to help certain parts of, you know, certain members of that family, and to say to other members of the family, you know, you're not going to get the same coverage as your child, or, hey teen, we know you get this coverage, but your brother and sister are going to get a different type of coverage. It was such a hard conversation to have, because we know what the right thing to do is. So what we've heard from our community partners is that people continue to struggle with getting coverage. You know, I ran into that experience over 10 years ago, and we're still running into the same issue after a decade. And what people are saying is that they're only one check away from being overqualified for OHP, and they're not able to afford health care. And it really keeps them up at night. And, you know, for our community partners, what they're saying is, you know, that we can't just provide services to people and then just, or not provide them and just get them out there and just, you know, you're on your own. People don't have anywhere to go. They feel lost in navigating their health coverage and bouncing back and forth between OHP and not having OHP and trying to seek coverage elsewhere. It truly is such a barrier right now, and it has been for a really long time. Another barrier we hear about is that members are unable to continue receiving services from their established provider due to their CCO not contracting with that provider. And I know from experience, we've actually had providers reach out to us to try to figure out how to get through that contracting process as well. People report concerns over access and availability of services for diverse communities. And so what that means is, like, you know, we might have a family who's going through a terrible loss. For example, with COVID, people have lost numerous family members during COVID, and they need, you know, they need that emotional support. And so when you have a family you're working with a migrant farm worker family that has lost several members of their household and they're living in multi-generational housing, loss after loss, that really takes a toll on a family and it impacts everyone in so many ways. And being able to see a provider that understands the culture, that looks like them, that sounds like them, that is something we hear from community partners every day, that it feels nearly impossible. And, families feel defeated in trying to find a provider that looks like them and sounds like them. So that is something that we are keeping track of, and we acknowledge we need to do a better job of this. Many CCO members are having to wait a long time to see a mental health provider. I think this also happens, when people want to see a specific provider, but just any provider. We're hearing that, sometimes people need a provider this week. They need that support this week. If there's been a loss, if someone lost a job, a family member, they really can't be waiting weeks and weeks and then having to go through interviews and all these different appointments before they can get to that person. It doesn't work. So we need to make sure that this is much more seamless. So comments addressed and challenges with waiting periods is definitely a key item we've captured. The importance of choice in provider. People want choices. We heard a lot about that during CCO 2.0. We heard clients say, don't tell me what's wonderful and what's great for me. Let me decide. So, don't say, look at this wonderful plan that we've put out there for you. We want to give people a menu of options and then they get to decide what works for them and really customize. So from tribal members and representatives, they spoke about the need for timely access to care for their communities and the availability of various choices. We heard the same from our tribal community. Members are not able to receive care when they need it. Delays in authorization. So if somebody needs to see a specialist, again, that came up a few times. And we tell community partners you can walk clients through the process of getting that pre-authorization with their CCO. But what we're hearing from community partners and from community members is that their experience is that it's a delay. And when people are sick and they have symptoms, going through the paperwork process and the documenting and having all the right people on the same page, it's really painful when people aren't feeling well on top of everything. Okay, so that's a lot. That's a lot to digest. And when I see this, I don't know what you're experiencing when you're hearing some of these barriers that were presented through the strategic plan and CCO 2.0, State Health Improvement Plan. But what I hear is like, we have a lot of work to do, and I'm excited about that. Like, it's a heavy lift, and it's a lot to process, but we can get there, and it's going to take time. Okay, so we've talked quite a bit about the bouncing back and forth, or as some people like to say, the churn, and that's where people have OHP, their income bumps up a little bit, and then they go into the marketplace plan, or maybe they slip through the cracks and they don't get that marketplace plan. There's a lot of confusion in navigating all that. So a lot of people end up without coverage who are actually eligible because they get lost in that fragmented world of, do I qualify this month or not? This happened a lot when I was on the North Coast and working with a lot of the community out there. There was a lot of seasonal workers. So income would really bump up during a specific season and come back down during another season. And who does this impact the most? It impacts our communities of color the most. And these communities are more likely to be uninsured. So pre-COVID, the uninsured rate for our Latino community was 12%. And for American Indian and Alaska Natives, 11%. For our Black or African American communities, 8%. For white community, 5%, 2 or more races, 4%. But this was all before COVID. So we all know, those of us who have been talking to our communities, that this has spiked. So we definitely recognize that. And just like one thing to be aware of with the churn, on average, we have 100,000 people who come back into the Oregon Health Plan each year who were eligible last year. So, I mean, when you think of how much work goes into filling out the application, getting proofs of income when we do need them, or other types of documentation, and then having to fill that out again, you know, that's a lot of work for our community partners. It's a lot of time, and it's not super efficient. And that's definitely something we want to acknowledge. And then Jessica, I imagine you're keeping an eye on the question box. Is that right?
I am, but I'm about to pop off to unfortunately another meeting. So
Okay, so we have Karina on the phone too. So I know she'll keep an eye out for any further comments or through the question box. Thank you for joining us today, Jessica. So in order to ensure all people have access to coverage, what we know is people need to have that coverage, and that we need to be sure it doesn't change or go away no matter what happens in their lives. So if somebody's hours increase a little bit in a month and they're going to go back down next month, we want to make sure that that person isn't churning back and forth and having to go through this sort of whack-a-mole just process. It's just really overwhelming. Changes to income are one way people lose coverage. Yeah, I mean, as mentioned. And so we need to be sure that we include more flexibility in who is eligible in the Oregon Health Plan in terms of income, but also, you know, immigration status, for example, making sure we're not being, you know, excluding people, but more inclusive. So our goal in that would be to ensure that when people get their OHP coverage, they stay covered. Our goal is to make sure people have an easier time enrolling with no wrinkles, eliminate inequities in health coverage. Absolutely, that is our overarching goal. We should be thinking about that when we wake up every morning. We should be thinking about that when we go to bed and throughout our day and every day. And it'll just be work that we're doing, not just this year or next year, but constantly. It will be evolving. Yeah. So we do have some potential strategies in this, and this would mean, you know, coverage for all people. I know a lot of our community partners have been a part of the conversation and idea of covering all people. So we are looking at that very closely, increasing outreach to make sure people are enrolled. And I love this word outreach because we say it and I think it's really important to say what outreach means. So outreach doesn't mean just passing a law and then saying we're done. Outreach means making sure we have materials available for our communities in different ways, as someone mentioned earlier. So for example, with COFA, making sure we have flyers available in multiple languages. We need to be proactive about those flyers and those materials and videos, and ensure that our community partners review them before we release them to the public, because they really are our experts. And with outreach is just to keep an open mind that what works for one community doesn't work for another. And we may need to adjust our outreach plan. So just being aware of that. It's like, okay, so far we've been doing social media, but that's not going to work forever. We need to do some in-person outreach. We need to get out there in person, put on our face coverings and 6 feet away from people, talk to them, about any new programs that we're going to launch. So if Cover All People is going to happen, we need to be really aggressive in that outreach and make sure it's linguistically and culturally appropriate. And then preserved enrollment in OHP. So this really just means let's look at what we learned from COVID and making sure we extend that. So community partners have said, hey, can you please keep the verbal signature idea going? So community partners can assist Oregonians with enrolling in health coverage over the phone and get a verbal signature. And this is something partners have asked to continue. So if you have mom who can't find childcare to make it to her appointment, or she doesn't want to go through finding transportation, or dad just can't get to that in-person appointment, you know, people will still be able to get that assistance from a community partner and that verbal signature over the phone. So that is something partners have asked to extend through the waiver. And maybe it fits there, maybe it fits out elsewhere, but it is something we've captured as a need. And then just making sure we're not asking for a lot of documentation and bumping people on and off OHP. So we'll talk more about this in depth in our coverage conversation, but I've shared a lot of examples, so I'm going to keep us going, and I'm going to check in and see if you have questions. So feel free to unmute yourself or add any questions to the chat box, and then we will move into an exercise to have a conversation about thoughts and experiences on these goals. Any questions? Let's see here. Okay, so we have some sort of general questions over eligibility, about how things are in today's world. So I would recommend you just kind of check in with your regional outreach coordinator, and because some of these are more like understanding eligibility. Essentially, most people right now shouldn't drop off of the Oregon Health Plan during our emergency period. There are some small number of exceptions to that, but for the most part, people should be keeping their coverage. Even if we ask them to submit something and they don't get it in time. So yeah, I just want to make sure you connect with your ROC if you have more eligibility current state questions if we get too weedy. Melissa's saying people may be eligible for OHP or insurance marketplace, but not everyone is computer knowledgeable or even has access to a computer. Also, just because you are eligible doesn't mean you can afford to pay for it. Absolutely, not everyone has access to a computer, and quite frankly, even if we did give somebody a computer, there are people who are not comfortable using a computer, or it may not be culturally appropriate, or that person just, you know, as much as they want to learn, may really struggle with a computer. We've heard that from some of our listening sessions as well. So people sometimes give up their words when they get on OHP, when they get an OHP closure notice in the mail, whether or not it was an error. So there are some people who in error are being, their benefits are being closed. And then that means they stop taking their medication and they don't go to the doctor. And some of these families, it looks like, or people you're working with, Amy, have HIV. So Amy is saying she wishes there was a system to follow up with clients after losing OHP to help them transition to the marketplace, or to see if they actually may still be eligible for OHP, just need help submitting the documents. Yeah, that makes complete sense. Amy, so we need to be asking ourselves, what does that outreach look like at OHA CPOP? Okay. So there's some questions about cycling in and out. And whether we have a process of people, maybe Lori, I don't know if you're aware of for the chronic sort of that issue of like turning in and out of care, is there a process for that sort of an outreach? And that came from Travis along with other individuals. Those are great questions. Thank you.
Yeah, I can address that a little bit. So one of the things that happens is when someone cycles off of OHP, we do send their information to the marketplace. So the marketplace is aware, and I believe they may get a letter. We have talked about, so it's I guess good to hear that we're capturing some of the issues, because we have talked about the fact that there isn't active outreach to those former members. You know, they get a letter from the marketplace, but often maybe they don't open it or they don't know what to do with it. And so one of the policy areas that we've been, Ruby and the team talked about was coverage. And in that coverage, one of the things that we want to do is try to keep people on the Oregon Health Plan as much as we can, so they don't cycle. And then also do more active outreach with the marketplace, so that somebody contacts them and says, hey, we know you lost your OHP coverage, but here's what you qualify for. So we are looking at that. And we also, right now with the pandemic, know that we're keeping people on even if they don't redetermine or don't re-sign up. And so we're looking at some of the pieces around that have been positive, so members can keep their coverage. So that's where we are. Also hoping, I'd be interested to hear comments from this group, but what I have heard is that not requiring income verification and being able to do applications with a community assister by phone have been real positives. We got those authorities because of the pandemic, but we want to ask for those moving forward after COVID crisis is over. But if there are any other ideas, then it would be really great to hear. So hopefully that's helpful, Ruby.
Yes, thank you. So if partners have other ideas, just any experiences that have really made your job easier in keeping people enrolled during COVID, please do add those for Lori and our team in the chat box. We want to make sure we capture that in writing. Thank you. Okay. So given that our goal is to keep people covered when they're enrolled in health coverage and make it easier for people to enroll, eliminate inequities in health coverage, what are your thoughts and experiences? What is standing in the way of us getting to these goals? If we're standing in your way, you're like, Ruby, you're in my way. Change this, change that. Let us know. Add it in the chat box. What do you think would help the most? Or if you've been dreaming up an innovative idea, if you've heard of something other states are doing that is working well. Maybe you have a cousin who lives in a neighboring state and you're like, hey, this is what they're doing there and it's amazing and it's working really well. Please do add your ideas in the chat box. And I'm going to give you all a moment to just do a silent review, to process and brainstorm and get that here in writing for us. Thank you. And then Karina, I have you on the line, right? Will you read some of the ideas or any input coming through the chat box? Just a quick skim of a few of those.
Yeah, I can do that. Let me get down here. Could they mimic the SNAP program where they do a long certification with a 6-month check-in and that's it, no other reporting requirements? And we have had several parents lose OHP due to change in family status.
Okay, looks like there's a few more coming in.
Yeah. Let's see. From the last one I just mentioned, there was one more addition to that. The one parent is no longer able to claim the children, or just a year-long certification with no reporting requirements unless it's a change in household members to leave or leave the state. Sometimes the notices to clients can be confusing when they're moving in and out of programs within OHP. They see one program has ended, but don't realize they just moved to a different program because of their age.
Thank you, Karina. Yeah, this is all really important to be capturing. So what I want to say is if you're thinking, if you're still processing, that's okay. Please keep just adding as we move along today. Okay, so Brenda's saying just issues with renewals. So issues with renewals to go on different coverage that they were on before, and it isn't one that we take in our office. So the parents are frustrated and they will not come back to us because they think it's from you. Okay, is there a way that they can see what program they were in before and keep them on it? Also, when adding a newborn to the family, it also has the same issue. So Brenda, do you mean maybe like the CCO when people go from one CCO to another? Maybe that's what you mean, Brenda? Or maybe I'm misunderstanding.
Oh yeah, Brenda said yes, the CCO.
Oh, okay. I understand. Yay, thank you. And then people just getting incorrect letters. That is, I can see from our chat box that's coming up a few times. So people who have Medicare get closure notices, and the notice says they're being referred to the marketplace when this is incorrect. People with Medicare aren't eligible for the marketplace, is what Amy is saying. Amy Thomas. It would be better if Medicare clients are referred to Sheba. So just a lot of confusion over all the different types of coverage being offered. It's still fragmented is kind of the takeaway here. So what will get us there, making it less fragmented? Oof, yeah, that's a lot of, thank you, Brenda. Thank you so much, everyone. Okay, so keep it coming. I'm gonna get us moving along and we are gonna talk about money. Yes, this is where a lot of relationship building takes place when we start talking about money, encouraging smart, flexible spending. And I know this is quite the topic. So I'm going to get us started and then Karina will be jumping in just a moment. So what we've heard is that a lot of times a person's health is impacted because of their basic needs not being met. So this could be as simple as just, not having enough food. I actually, when I was assisting with the Oregon Health Plan years ago, I worked in a food pantry and it was part of a youth organization that worked in the school district out in Washington County. And through that food pantry, we were able to fill a box full of food and talk to families about health coverage. We'd build the relationship around food of all things. Once we had a conversation about, what items were needed, people would open up and say, actually, I also need health coverage and I don't have that. Like, do you know anyone who can help me? But having those conversations meant scheduling appointments and offering home visits. A lot of the families we worked with wanted home visits, so we'd drive to them, sit down and have a laptop with a scanner, and we'd walk them through the application. And I still remember someone saying, I can't remember the last time I was able to put any fruit or vegetables in that bowl over there. And there was a bowl on the table and literally like one piece of fruit. And she said, I just want to be able to get fruits and veggies into this bowl. If I can do that once a week, I will feel so much more at peace. And so these are the types of things that we're hearing is we need to be sure that we look at someone's health from a very basic place. And who better to say what's needed in our communities than parents, brothers, sisters, families, faith leaders, our community partners like you. You've been saying this for a long time. People need their basic needs. And where we struggle is that CCOs can't fully do much of this needed preventative work without a more flexible budget. So we want to move in that direction. That's what we need to do so that people can access healthy food. And people have that bowl on that table is full of veggies and fruits, and people don't need to be thinking about those very basic needs. CCOs will have an opportunity to help normalize access to the most basic needs. A lot of times parents want support with maybe like, parenting conversations. We may have parents who are in need of understanding what their youth are asking for and how to connect to resources at school so that they can offer the strongest parenting support. And so being able to give CCOs a flexibility would mean to offer families flexibility as well and customizing their care in a way that works for them. So, when we talk about these basic needs, we're also talking about housing, assistance with unemployment benefits and assistance with getting a job, assistance with transportation. These would really all be super helpful in making sure our CCOs have that flexibility. Another barrier we heard from our listening sessions with our community partners and in our conversations and meeting with community members is the need for childcare. There's a lot of barriers and stressors for low-income families, especially for our communities of color. So that paid childcare is very much a top priority. It's a big ask that we continue to get. And I shouldn't say big, I should say it's a very simple ask that we shouldn't be really struggling with. And I think that's something we've really learned from this pandemic is to really appreciate teachers and parents. I'm sure a lot of you just like me are just kind of thinking, oh my goodness, like, childcare is really difficult, especially when you can't access it. So, in general, before the pandemic, there was a lot of challenges finding daycare centers, and that has just been perpetuated with our pandemic. So making sure, again, that we are working with our CCOs to improve reimbursement and making sure that budgets are flexible so that you as CCOs can work with communities and ensure that you're addressing determinants of health is really key. And seeing more of those incentive payments going to our community advisory councils to carry out these projects. And of course, any project would be with communities leading and communities telling us what they need. Okay. So one of the hottest topics, I would say, hot topic of the years has been housing, and what a barrier it's been to find affordable housing across our state. People don't have stable housing. They didn't before COVID, and this becomes so much more difficult when you have a multi-layered situation. You know, when you're having to figure out where you're going to live, that's really at the top of your priority, and it gets in the way of making sure people get an appointment, scheduling that appointment with the doctor, filling out their intake forms, knowing how to get connected to that mental health provider, getting their medications, and checking in with the pharmacy, and finding transportation to a pharmacy is a barrier in itself. So when you have all these obstacles in front of you, especially for our communities of color, especially for our immigrant families, you know, the last thing people do is think of their health. And so we need to be sure that affordable housing is at the top, and that we really are addressing our social determinants of health, but keeping that laser eye focus on affordable housing. Okay, so I'm going to go ahead and just touch on a few things that have come up in our conversations with affordable housing. Is like sometimes people do have housing, but they also have mold in their unit, which makes it difficult to think about, you know, going to work if you're sick. So something like having access to like an air purifier or an advocate to work with the landlord to be sure that that mold is taken care of, and really advocate with a family so that they're not, you know, in fear of being kicked out if they speak up about that mold problem, is an idea. Housing is too expensive and not suitable for living is just the overarching concern all around. So just a little tidbit here for those of you who appreciate numbers. In the CCO 2.0 stakeholder survey, 72, almost 73% of you responding ranked housing as one of the top 3 areas that need to be addressed. So again, very much a hot topic. So this is what we've heard from CCO 2.0. We've heard you loud and clear from our strategic plan, state health improvement plan, and through our COVID listening session. And we appreciate what we've heard. Please keep it coming. We know some of this has not, a lot of it has not changed, and a lot of work needs to be done. I've already talked quite a bit about this, Karina. I don't know if you want to add anything, but you are set to jump in for me here. Thank you.
Yeah, thanks, Ruby. No, I think you've said everything, but I can just quickly read off the slide as well. So providing flexibility in the way services are provided and what's covered, and encouraging CCOs to focus beyond the medical system and pay for things that truly keep people healthy, as the list of examples Ruby has given us earlier, and that our waiver renewal will continue to push for ways to improve the value of healthcare spending. So I'm going to go ahead. Oh, Ruby, can you go to the next slide? Sorry, I forgot I'm not the one controlling it. Thank you. So our goal then is decisions about community investments are made by the community itself, and that people will get the care and support they need to stay healthy. So some of those potential strategies could be true flexible spending enhanced for CCOs, which would allow for CCOs to focus more on social determinants of health. Community managed funds for investment in equity and social determinants of health, as well as cost control mechanisms for high cost, low value care and services, and increased CCO accountability to health equity. And now we'll stop again for questions as well.
Karina, I will look in the chat box and see if any questions come up. And then again, we invite you to unmute yourself if you'd like. It looks like someone has raised their hand. George Adams. So I'm going to try to unmute you. Let's see. Actually, you might be able to unmute yourself, George. Did that work?
Yep.
Wonderful. Thank you.
Has with this Medicaid stuff and housing and all that stuff, is housing considered on the disability side of things? Or is, because I know housing has been a big problem. And I was wondering if housing on the disability side has been considered.
Yes. So when we're talking about housing assistance and making sure that our CCOs have flexibility around that, I think, that is very much focused around people with complex needs and social needs. And so I would definitely say that absolutely covers people with disabilities. And that is the goal. And I would also add that some of our community partners have stressed the need to just make this like a very basic service for people to be connected to housing, meaning like everybody has access to an advocate that would walk them through accessing housing, whether they have chronic health issues or not, or if someone's not disabled, just the fact that they've identified this as a need through maybe a community-based organization or in conversation with their faith leaders, or perhaps at a doctor's appointment. We've had community partners say it would be really wonderful if we could just connect people to housing assistance, walk them through those applications, and find somebody a place to live and cook their meals.
Well, a House representative and a senator has already informed me that the housing aspect of people with a disability is first in line on the governor's list.
I appreciate that. Thank you. Thank you. That is so important. I really appreciate you bringing that up too, because with our waiver, when we talk about health equity, that includes people with disabilities, absolutely. And so we need to be sure that we have dedicated programs and dedicated outreach, that we're having these conversations with our community partners, and that we're connecting people to services, absolutely. Thank you, George.
Yep.
Does anybody have anything else to add? And you're welcome to turn on your camera if you prefer, or any thoughts. Oh, it looks like we do have some ideas in the chat box coming through. So I want to just encourage you to look through the chat box when you have a moment. There's a lot of talk over how to support traditional healthcare workers within CCOs. Yes, absolutely. Some of our CCOs are doing a lot of great work with traditional health workers, and there is a wealth of information in connecting our community members to things like housing resources. So Melissa says, one issue, no matter what your social economic status, especially for those who are on food stamps and those who have limited food budgets, is the amount of processed food. The amount of carbs, salt, and sugar in the processed foods is very harmful. It seems to me some education around understanding portions and labeling should be part of support. And then acknowledging that there are families who cannot eat dairy, salt, gluten, dark leafy greens, and nuts. making it difficult to provide safe meals for a family. So that, thank you, wow. So an idea would be to expand farm coupons. So that's definitely something that should be happening. You know, people should have access to fruits and vegetables that they can eat. Oh, I hear you on the, you know, restrictions and allergies. My dad has a lot of food allergies, and it is kind of spendy. I'm not going to sugarcoat it, and it's hard to track everything.
Hey, Ruby, I want to make sure we ask Alicia's question. I'm still unclear, and my apologies if I missed it, exactly what the waiver is waiving.
Yeah. So I know the word waiver really threw me off when I first heard it. And I wonder if I want to kind of explain how I understand it. And then Lori, if you could clarify. But every few years, Oregon has an opportunity to say to CMS, hey, this is what we're hearing from our community, and this is how healthcare should look in Oregon. And essentially, this application is submitted, this waiver application, CMS will give final approval. And so I would say it's more sort of, it feels to me like a little bit like an experiment of how we can save money and achieve the triple aim. I just want to give Lori an opportunity to kind of help us really, it's a little abstract for us. So if you could help us really clarify and bring it down to, at least for me, just I would love to hear it from layman's terms.
Sure. And I mean, everything that you said is right. And I'll expand on it a little bit because the question gets right at the point. It's a waiver. What are we waiving? And at the very beginning of this presentation, we talked about how there's kind of basic, the federal government, the Center for Medicare and Medicaid Services outlines for each state what the basics are for administering or running a Medicaid plan. Like, and in our state, it's the Oregon Health Plan. In Washington, it's called Apple Care, for example. And so we have, and there are federal rules that we have to adhere to in order to get the funding from the federal government to run the Oregon Health Plan. And like Ruby said, states are allowed to say, hey, we can provide better care at either the same or lower cost if we do these things, whatever that is, whatever our ideas are. And in order to do that, we have to get a waiver of some of the rules, of the rules for the Oregon Health Plan that are federal rules. So we say, for one example, I'll just give a concrete example. So there's a thing called statewide-ness. And what that means is if we followed the federal rule, you have to have a health plan that's going to cover Medicaid members like a CCO. It has to provide services statewide. That's a federal rule. So in our waiver, one of the things that we always ask for is to have a waiver of that. And that allows us to create CCOs that are local and regional. So that would just be one little piece. So there's lots of ideas that people have given here today that we don't need a waiver to move forward. And it doesn't mean that we won't. It means that we might be able to do something like change a contract or use what's called the state plan amendment, make some changes that are much faster and easier. So for this big waiver that we apply for every 5 years, we actually ask the federal government to waive certain federal rules for how we have our Oregon Health Plan run. So hopefully that's helpful. And what we do, we get feedback like this. This is really amazing feedback we're getting today from everyone. And then we sort it and say, okay, these are things that we have to ask for a waiver, a federal rule. These things over here are, we can look at other ways to achieve them that are a lot simpler. Like I said, we might change something in the CCO contracts, for example, or we might work with Vivian Levy and her, who's in my, in the Medicaid team, and she oversees eligibility policy, and we might figure out ways not to have notices say, you know, when someone ages out and they need to go into Medicare, so the notice doesn't say they need to contact the marketplace, and we correct those notices, and that's something that we can do internally. So hopefully that makes sense. And I don't know, Ruby, just let me know if you have any other questions.
Thank you, Lori. All right, I will give it back to you, Karina, to start our exercise, and I'm going to move the slide here for you.
Thanks, Ruby. And I also see that George has their hand up. So I'm just go ahead real fast, George, to explain this, and you might have also something to add in here because it's open now. So your thoughts and experiences, what is standing in the way of us getting to these goals? And the goals are the decisions about community investments made about community itself, and the people will get care and supports they need to stay healthy. Sorry, Ruby, could you go back? Thank you. And what would help the most? And before, like folks, you can go ahead and start writing into the chat box, but I want to make sure that George gets a chance to also speak.
Sorry, Karina, I was trying to unmute George and then I accidentally advanced the slide. It looks like,
Okay.
there you go.
Have you guys been keeping an eye on the waiver that Mr. Kitzhopper wants to introduce? The one, the 1332 waiver to combine with the 1115? Or can you tell us more about the 1332 waiver?
You know, I specifically cannot speak to that, but maybe Lori can. I'm not sure.
I can at a high level. So like the team shared early in this presentation, there's lots of different kinds of waivers actually that we can apply for with the federal government. So another example is we have a lot of waivers in how we provide home and community-based services for some of our disabled members to keep them out of nursing homes. That would be another area where Oregon, we have a long history of doing that, and we had to apply for a different kind of waiver. So there's also a 1332 waiver. What that waiver is for is really to waive marketplace requirements. And we are looking in the one policy area around coverage is potentially making some changes in this waiver, our 1115, but then also looking at some marketplace changes so that we can cover more people in Oregon. Our goal is to cover 98% of Oregonians with health insurance. That last 2% are people who are just gonna not want to apply. Or feel like they don't need health insurance. So hopefully that helps, but we are starting that. The 1332 process will happen after this 1115.
Thank you, Lori.
Okay.
George, did you have any follow-up questions?
Yeah, that was a good answer that I was searching for.
Okay, thank you.
It looks like Marla added into the chat box that for the rural clientele, transportation is a huge barrier. The local transportation programs are expected to transport everyone to their medical appointments. but in more and more cases, there is no transportation mileage reimbursement for transportation purposes to offset the costs.
Thank you, Marla, for that. I do have, so Marla, what county are you in? You could put that in the chat box. Gillum, okay. Yes, we've heard this. It's also been a huge barrier for people who are over 65. Getting transportation to and from medical appointments has come up, or having transportation consistently show up has been another challenge we've heard about through our community partners as well. And it looks like in smaller counties where people have to travel 1 to 2 hours one way for medical services, it's a major concern. And Marla's reinforcing exactly, the transportation eligibility expires when they turn 65. And, you know, for those of you who are in counties where you have that robust transportation resource for people over 65 and over, that's wonderful. There are definitely communities across the state where we were doing our community outreach and learned that it just felt like the older people got, the more people worked with older adults, the less services they had, which our partners have reported feels very backward. Seems that with older adults, we would want to ensure they have the most fruitful services, and that is not consistently the case. Thank you. Okay, Karina, well, keep the questions and input, the feedback coming. I'm going to keep us moving along so we don't run out of time.
Thanks, Ruby. Okay, so reinvesting savings across systems. Move into this section now. So what we've heard, people want investment in programs to support their health and healthy communities. So a couple quotes here. I think it'd be great if OHA could partner with the Parks and Recreation Department or maybe community centers to give free or reduced price gym memberships for a more proactive approach to health. And preventative health is so much cheaper than treating the problems, the conditions, the symptoms. It is so much cheaper. It's just so much better. You don't have to go through a lot of pain, and it costs everyone much less. Both very important quotes, and I think we can all agree that these are some of the ways that we can easily improve healthy communities. Reinvesting savings across systems. So society-wide issues that cause health inequities often go beyond the scope of the healthcare system, and our waiver renewal will seek to reinvest savings to combat health inequities at the statewide level. So that's really one of the goals of the waiver, is to reinvest the savings that we get from introducing this waiver to meet those health inequities and really eliminate them. So our goal, the savings generated through health reform are reinvested to address the social needs of members with complex needs, and resources are shared with other state agencies so that investments in projects that need large-scale funding is coordinated so that we can all work on these, on addressing these needs at a statewide level. And to our next section, another break for questions.
Karina, I'm going to look in the chat box here and just, it looks, oh yay, George raised his hand. Thank you so much, George. Do you want to unmute yourself?
Yeah. I've got I'm the chairperson for TransLink down here in Southern Oregon, Jackson County, on the TransLink medical board underneath the CCO. Is there any chance of this new Medicaid waiver? Will it be allowing people over the age of 65 through Medicare to have transportation to take them to medical appointments to help us transport them?
Lori, do you want to jump in?
Sure, I'm happy to. No, unless they're a dual eligible, and what that means is the member is a low income senior that continues to qualify for Medicaid and Medicare. But if for people, once they turn 65, they switch over to Medicare, and our waiver does not affect Medicare benefits, if that's helpful. So if they have Medicaid, then they should still qualify for rides.
But is there a way where Medicare can be involved in a TransLink CCO transportation setting over the age of 65 for us to transport them? Can that happen?
No.
Something set up?
No, unfortunately, unless the CCO is willing to set up something through the Medicare Advantage plan, and that's kind of that's not part of what we can cover under Medicaid.
Okay.
Yeah, sorry about that. I know it's a need.
Well, there's 25% of people over the age of 65 and it's going that needs rides to medical appointments down here.
And George, just so you know, we're capturing all of the comments that are coming through the chat box. And so this has been something we've identified. I'll be working with my team to figure out, like, if there's suggestions, change that needs to happen and it lives outside of the waiver, we'd like to be sure to direct our community partners to the right place, because I know our community partners want to advocate, and some of them are already emailing and asking, okay, well, if my idea or solution or issue doesn't live within the waiver, what do I do? How do I get it to the right place? And so just to know that we're working on that, and we will be circling back with this group. Thank you, George.
Okay.
So I have a question.
Yeah.
Okay. So I have someone I was helping, and they needed they were able to pay for a hotel room up in Portland for appointments, but they didn't have like Bay Cities, because I live in Coos County, wasn't able to take them up to the hotel. And they wouldn't be able to go up the next day, and the patient's CCO is Advanced Health. They don't cover the Portland area.
Yeah, so for transportation, when people are needing to go from county to county, you're saying that's a barrier?
Yeah, like he doesn't know anywhere up in Portland that would be able to take him from his hotel to all of his appointments, because Bay Cities they don't cover the Portland area.
Okay, I'm actually going to put our general inbox email address in the chat box. And if you could just send us more details on this case, what we can do is work with our ombuds team and make sure that we're getting clients what they need. So there's going to be items that come up today that are related to current issues that need to be resolved, and there might be things that live within the waiver at a later time. So I'm just going to go ahead and put our general inbox here, and just make sure if you could send that via secure email, that would be great. Or you can call me directly, and I can add my cell phone number here.
Okay, thank you so much, Ruby.
You're welcome. So Jennifer did mention clients can also contact their county ADRC to apply for, Jennifer used an acronym there, Medical Savings Program. Is that what that stands for?
Correct.
Okay, thank you. Tammy is saying she agrees with that, Martha, and Pacific Source is great at working with us to ensure individuals have ongoing services to keep them healthy. Okay, because Martha was saying the problem is not just housing the houseless. 99% of the work starts once housed. That is when the flexibility comes in handy. I love to just get people housed and I love to just get people housed and wish them well, but that is not the case. Some of these folks require more assistance, support, and more resources. This is where the CCO support becomes really critical. Yes, we've been having a lot of conversations about community partner engagement with our CCOs in our collaborative meetings for the last 3 months. We've really been highlighting that. It's very critical that you know who your CCO contacts are. So for example, if you get somebody into their own apartment, but then they need a mobile phone so they can participate in their telehealth appointments, or maybe they need internet access, they need to be connected to someone to help them coordinate their care if they have, multiple appointments and specialists. It's very critical that that coordination is taking place and that our partners are having those conversations, and likewise that our CCOs are reaching out to our community partners to engage them in conversations and get to know one another. And that really just helps us all work together, bring down the silos, and troubleshoot some of these cases.
All right, can we go to the next slide, Ruby? I want to make
Yes.
sure we have enough time to finish
All
up
right,
today.
moving on.
Okay, so we're back to another slide looking for more input. So now your thoughts and experiences, what's standing in the way of getting these goals and what would help the most, but looking at the goals of the savings generated through health reform are reinvested to address the social needs of members with complex needs, and resources are shared with other state agencies so that investments in projects that need large-scale coordinated funding.
Well, I mean, I think that what Tammy, maybe it was Martha, what Martha shared would get us to our goal. If we could acknowledge that it's not just about giving somebody a place to live, but that ongoing coordination and walking alongside someone to make sure they have everything they need, all the resources and connections and support would get us to our goal. That's a really good example. Janet is asking if OHA currently has a surplus budget, or are you asking about savings based on improvements made with the waiver?
The question says the savings generated through health reform are reinvested to address the social needs of members with complex needs. So I'm just we're just talking about you're going to save money with waiver things, and that's what you're talking about, or I'm trying to get my mind wrapped around exactly what you're saying here.
Yeah, Lori, I think this might be something you could speak to a little bit, but I think this is more related to our CCOs and making sure, well, there's the first part of making sure CCOs have flexibility, and then there's the second part of making sure that any shared savings go to addressing the determinants of health. But maybe this is something that you could speak to a little bit more.
Sure. So I think it's right. I mean, you have it right in that we want to create a way for the CCOs to have more flexibility in how they spend their dollars. Right now, the way that we pay the CCOs is based on what their how much they spent on medical services in the prior years. And what we want to do is include what did they spend on medical services for members, but also on their spending on social needs. And so, you know, how can we do that? And then if they're given that opportunity, what are the types of investments that you'd like to see CCOs make? So we know one thing is Center for Medicare and Medicaid Services will likely not help allow CCOs to pay to build housing, but they will allow CCOs to pay for things like housing supports. And I think when you were talking about once a person is housed, it's all the rest of the things. That's what we're talking about. So rent, you know, getting them in the place so they, you know, we cover first and last month rent, help buy furniture, get food in the refrigerator, and then also navigation supports, you know, after there's things called tenancy supports so that people learn how to be a good tenant, pay their rent on time, and those sorts of things. So so those are the ideas that we're looking for. It's where the biggest needs are.
Thank you, Lori. Okay, so we are running out of time. So Karina, I'm just going to get us moving along here. Just a final reminder that when we are talking to, or when we are applying for our waiver, health equity, advancing health equity is the overarching goal. So that really is at the center of the work that we are doing, and creating an equity-centered system of health is basically what we're talking about, ensuring access to everyone in Oregon to cover all people, ensuring smart, flexible spending, and reinvesting savings across systems, like we just talked about. So the question really is, how will we continue to work with our community partners and ensure that we're getting feedback from you? So remember, this is going to be our first meeting. We're going to be offering this as a series. Keep an eye out for a meeting invitation. If you have coworkers who missed meeting 1, it will be recorded and that will be posted shortly. We'll be in touch with you about that. We hope to have our next meeting hopefully by July. And if you have coworkers who speak Spanish, they can actually participate in our meeting Thursday, May 13th. That will be in Spanish. We'll continue to offer this series in both English and Spanish. If you have any other language requests, please do email them to our general inbox. So know that this is not the only conversation, but only the first conversation as we move along. We also have waiver workshops, and some people are referring to these as waiver days. These are going to be starting late in May. So we will be getting more information out about this. The sessions will be divided into 3-part technical work group series. And so this will align with our timeline as we begin to develop content. And it really allows for us to really deep dive into each of the goal areas. And again, those are just kind of squared away over here to the right, are very important goal areas that will lead the way. So in May, we will look at defining the problem, looking at the drivers and barriers. Early summer, we'll look at potential strategies and theories. And then later in the summer, we'll look at the details and really get into the weeds, meat and potatoes of things, quality and evaluation. So for those of you who are CCOs or the hospital association, you would fit into the industry category. The meetings will be 1 to 2 hours long and will be offered, let's see, I think right now in English, but if you have any language requests, please reach out and we'll see what we can do. OHA will facilitate the work sessions, so we will be leading those with you and making sure we answer questions in each one of those opportunities. A summaries of feedback will be coming your way as a follow-up, and decisions will be documented along with the reasons for the decision. So those will be communicated out to all of our stakeholders and community partners. Okay. Any questions so far? So just know we will stay in touch and continue to reach out to you and let you know what the follow-up opportunities are. And it looks like George has a question. Yes, George.
With this waiver and such, come September, when the United States government will be removing the asset level for all states on the Medicaid, making it more for people that want to be on Medicaid. How are you guys handling or will be handling that big situation where there's going to be a flood of people with the asset dollar amount being removed come September in the Social Security reform? And can I please have this PowerPoint sent to my email too, please?
Absolutely. We will be following up with the recording, and we can send the PowerPoint as well. So I think what you're asking about is staffing. Do we have enough staffing if we have a flood of additional Oregonians enrolling in Oregon Health Plan? Is that right?
Yes, once the United States government does the Social Security reform in September, when they remove the asset dollar amount and the amount of money that you're supposed to be having in accounts, how are you guys going to handle that with a flood of people once that is removed?
You know, Lori, do you know what the plan is for staffing if that's something that we experience?
I don't know yet. We will have to get more guidance from the federal government and just be watching that to see what happens. So thank you for your question.
Okay.
Thank you, George. I appreciate you flagging that for us. Okay, so with all this information, I know it's a lot to digest. The question really is, are we on track? So we pulled a lot of this information, as I mentioned, from our community partner COVID listening sessions, or from CCO 2.0, community input, the strategic plan, and state health improvement plan. So the question is, hey, community partners, are we on track? Is there something we need to adjust? Are we hitting the mark, or what is it that we're missing? And so what I'm going to go ahead and do is open up an opportunity to discuss that. And I know some people may need to go, so if that's the case, I completely understand. So I've put in a poll here and I'm launching it, so you should be able to see it in front of you. Based on community input we've heard so far, are we on track? It looks like it's on there twice. Not sure how that happened, but I guess we'll get your response twice. We'll hear it twice from you. This way we don't miss what you're saying, right? You're going to tell us twice. Okay, it looks like 33% of you have submitted your response. So based on what we've heard so far, are we on track? Yes or not yet? Okay, so I'm going to close this up here in just a few seconds. So hopefully you've had time to give us your response. All right, so you should be able to see the results here in just a moment. So it looks like mostly yes and a little bit of not quite. So this is good. We're going to keep having these conversations. We're going to keep hearing from you. So keep an eye out for the follow-up. We will be sending a video of this recording so you can share it with your community members. Send input to the email address here in front of you. So that's 1115waiver.renewal@dhsoha.state.or.us. Thank you so much for taking time out of your day. I know some of you have been working on COVID vaccine sessions and community events. So I so appreciate those of you who needed to schedule and move things around differently so you could be here today. And we're gonna close this here in the next 5 minutes. So if you have any last few thoughts to add in the chat box, you still have time. Thank you. Thank you, Karina. Thank you, Lori.
Thanks for having us, Ruby.
Patricia had a question for you, Ruby.
Thank you, George. Hi, Patricia. It's good to see you.
Hey, it's good to see you too.
You know, to be quite honest with you, thank you, George, for bringing that up. I'm still learning about, I think you're referring to the asset dollars in
Yes.
September. I'm still learning about that. I really can't speak to that. But probably, George, it sounds like you might have more information about that than I do. Or if there's someone else on the call who wants to speak to it, who feels like they've been in it day in and day out.
Yeah, what's going to happen is come September, they're going to be doing a Social Security reform, which means they're going to be wanting to bring the poverty people on the bottom and bring them up to the medium side of things. Taking the asset level out, giving more people an opportunity to have more money in their pockets to spend whatever they want to spend it on, needs and so on and so forth. And then and also being able to still qualify for other services without that asset dollar amount. Oregon Human and Health Services, for example, requires by Medicaid, you can't go over $2,000. Well, they're going to remove that come September if it passes.
Thank you, George. So Pat, what I can do is reach out to our policy team and get more information in writing. And we would be happy to share that with all of our community partners via our collaborative meetings and our community partner newsletter.
Okay, thank you.
Yeah, thank you. Okay, well, it looks like we don't have any other questions. So I'm going to go ahead and close our meeting today. Thank you to all of you who took time to join us. Take good care of yourselves.